Good afternoon, everybody. I'm really excited. Thanks, Lisa and Concilium, for inviting me. So let me just get started right away. Sickness used to happen to you. Now we live in a world where it is being sold to us. We are constantly bombarded by messages of new disorders, new diseases, and the pharmaceutical solutions, basically a pill for every ill. Selling sickness is a global phenomenon. Diseases and medications are promoted, boundaries that define illnesses are widened, drugs are overprescribed, and doctors' offices overflow with people asking for more out of their healthcare. The selling part really reflects the reality that there are commercial interests that play a huge role in healthcare. Drug companies are commercial enterprises, they are businesses. They not only develop innovative medications for severe diseases, but also ones for lifestyle problems and the prevention of potential health issues. A lot of money is being invested in marketing to patients, consumers, and the healthcare profession. It's no wonder why Americans take more pills than ever before. We are about 5% of the world's population, and we consume almost 75% of all prescription drugs. I love this quote by Henry Gadsden, Merck's CEO. He, in an interview to the Fortune magazine, he basically said he wanted to sell to everyone, cradle to grave strategy, really making it like Wrigley's gum, where his dream is to make healthy people take pills. So that's really the platform in which we start from. The US is one of only 2 countries in the world that allow drug advertising to consumers. I love this quote by Arthur Caplan. If you got the advertising dollars, you can turn almost anything into a disease. Pharmaceutical companies spend over $480 billion every year. 95% is on marketing and 5% on research and development. Science and medical research can be perverted for marketing purposes. Again, healthcare is big business. Safe and effective. Everywhere you turn, everything, medications, the medical interventions are touted as safe and effective by everyone. But are they? I always love this picture of the iceberg because it's really what's below the surface. We've been convinced to accept the term safe and effective without questioning. We assume the safe and effective drug we are being prescribed will help, certainly not harm. No drug is completely safe or without side effects. Drugs always have an effect, otherwise they wouldn't work. So there's always risk to some people, even if minimal. So to call a drug safe, completely safe and effective implies that it can only be good for us, and it's misleading. And words do matter. Every year there are over 128,000 deaths from properly prescribed safe and effective medications. It's the 4th leading cause of death in America. And I truly believe that if the public understood and were aware of the frequency of which patients fall victim to harm, it'd be a much bigger societal outcry and response. However, a lot of harms are often invisible and they happen one at a time in isolation. So it's harder to link to the bigger systemic problem. Now, I was recently, I had this number, and I know this is a number that's been pretty widely accepted in the US. And Peter Gacci had brought it up to me that he actually believes it's even higher than the 4th and maybe the 3rd, 2nd, even 1st that could be harms from. So whether it's 4th, 3rd, 1st, the reality is there's just a lot of harms that are happening in our medications that we are taking. And if it were like an airplane going down every single day, what do they say, 35 of them, we would be paying attention. But instead, like I mentioned, it's usually isolated. So you may be wondering why somebody like me, who has spent her entire career in advertising and marketing and not healthcare, is interested in this concept of selling sickness. Well, I came to this business accidentally. It's why I like to call myself the accidental advocate. Unfortunately, I know only too well the high price of a flawed drug safety system. I never set out to do this work, but sometimes our greatest purposes choose us. This is my husband and me. It's February of 2003. We're happily married for almost 10 years. We both have successful careers, traveled the world, and started talking about having a family. However, on August 6, 2003, while I was out of town on business, I got a call from my dad that changed my life forever. My husband, Woody, was found hanging from the rafters of our garage, dead at age 37. Woody wasn't depressed, nor did he have a history of depression or any other mental illness. Woody had just started his dream job with a startup company and was having trouble sleeping, which is not uncommon for entrepreneurs. So he, being the athlete, where the doctors have fixed his broken bones, stitched him up, he went and did what he would do normally, and he went to visit his doctor and was telling him that he was having trouble sleeping. The doctor gave him a 3-week sample pack of Zoloft and told him it would take the edge off and help him sleep. 5 weeks later, Woody was dead. Shortly before and ironically, when he was given the drug, I was out of the country the first 3 weeks that he was on the drug, so I wasn't even there to see his slow demise. But shortly before his death, I will never forget, Woody came home completely drenched in sweat through his blue dress shirt, fell to the floor and put his hands around his head like a vice. And he's like, "Kim, you got to help me. I don't know what's happening to me. My head's outside my body looking in." And he's bawling. And he said, "I don't know if I could ever handle one of these again." He said he was losing his mind. We eventually calmed him down. We did yoga breathing, we prayed, and he eventually called his doctor. And the doctor told him it takes 4 to 6 weeks for the drug to kick in. The night Woody was found, the coroner asked if he was on any medication. Zoloft was the only medication Woody was taking. She proceeded to tell me she needed to take the bottle with her. It might have something to do with his death. Ironically, on the same day that Woody was found, the front page of our local newspaper had an article that said the UK finds link between antidepressants and suicide. From the beginning, Woody's death made no sense. Why would a guy who loved life take his own life? We never questioned the drug. Why would we? It was given to him by his doctor. It was sold as safe and effective, and the FDA approved it. At the time of Woody's death, there were no black box suicide warnings. However, my brother-in-law Googled Zoloft suicide and learned that the FDA held hearings in 1991 on the emergence of violence and suicide with Prozac. At that time, all of those members on the committee, almost all of them, had financial ties to the pharmaceutical companies making antidepressants. And the FDA said, study suicidality, they never did. Eli Lilly never did. The FDA never followed up. So here we went. So we started digging into how Woody went from not being able to sleep, feeling outside his head looking in, and hanging in 5 short weeks. With binders in hand, my brother-in-law and I got on a plane and headed to Washington, D.C. We were determined to make a difference, to make sure that no other family would learn the hard way. We met with the FDA, we met with HHS, we met with members of Congress. We even helped with the Energy and Commerce subcommittee investigations that eventually led to congressional hearings on antidepressants. I had a failure to warn wrongful death lawsuit against Pfizer. And Woody's story, cautionary story, was featured in media around the world. Ultimately, we helped get a black box suicide warning added to the antidepressants in 2004 for kids and 2006 for young adults. To think this was 13 years after the FDA first had hearings with the Association with Suicide and Violence. How many lives were destroyed before the FDA finally warned consumers about the risk with antidepressants? There are many lessons from Woody's story. One, there's inherent built-in trust. You know, Woody did what most Americans do. They put their faith and trust in the doctor and assume that the FDA-approved drug being prescribed will do good, not harm. They're too quick to prescribe or recommend. Should meds have really been the first line of treatment, or were there other evidence-based non-drug interventions that the doctor should have tried first? Diet, exercise, talk therapy, or the option of doing nothing at all should have been tried first. I blame the influence of marketing and direct-to-consumer on this quick fix culture. Then, of course, there's the lack of recognition or understanding of drug side effects. This often leads to layering more and more drugs to deal with side effects, and the cascade continues. Samples were given to Woody without any discussion of side effects. A meaningful conversation never happened to truly assess the risks associated with taking this powerful, mind-altering drug. This is why shared decision-making and true informed consent is so important. And then there's off-label. You know, this is a huge problem, even if it's considered standard of care. Patients have no idea that the drug that they're being given for a condition wasn't even FDA approved. They wouldn't even know to ask. I know in Woody's case, you know, antidepressants are given to everything. They're given depression, anxiety, insomnia, PMS disorder, social anxiety disorder, grief. Unfortunately, physicians are misinformed about the dangers of antidepressants and are so often cavalier about their use and believe there are no risks in adults. To this day, there still is no warning for anybody 25 and older. SSRIs are not benign and certainly not a daily vitamin. Then there's a lack of understanding of how the FDA approval process works. I was shocked that doctors don't learn how the FDA works in med school. And then there's the role of lawsuits, and the legal system is essential, and it's our checks and balances, and it's the only way that we can get inside company files. The FDA can't, Congress can't, and the government can't. Initially, I thought this was just an isolated situation with just antidepressants. However, I quickly learned it's a much bigger systemic problem with our nation's drug safety system. It's a system that's driven by commercial interests, compounded by issues such as lack of transparency, conflicts of interest, undue industry influence with marketing and PR spins, using ghostwriting, key opinion leaders, manipulation of clinical trials, industry-funded screening tools, and the role politics and the revolving door plays within the FDA and regulatory agencies, Congress, and Big Pharma. Plus, there's the plain fact that the system is designed to promote benefits and not harms. And to top it off, I don't really think anybody actually ever thinks anything bad will happen to them until it does. Like, I know we didn't. Before Woody died, I had this naive attitude that most lawsuits were frivolous. You know, like people suing McDonald's for burning themselves by putting extremely hot coffee between their legs while driving. I subsequently learned that this was a very important lawsuit that changed the temperatures of coffee being sold. Discovery holds the key. And so there's discovery in lawsuits, there's FOIA lawsuits and whistleblowers, and I'll get into that in a little bit. But discovery really holds the key to unlocking wrongdoing, giving insights to the efforts to keep important safety issues under the radar. Discovery allows for lawyers to get inside the company and obtain internal company documents, emails, and communications. Interestingly, I found that the marketing department is often one of the first places that the lawyers go during litigation. My lawyers were strategically able to get previously discovered internal company documents declassified and made public. For years, Pfizer and all the other drug companies have long argued that these documents were trade secrets. The only thing secret is that they hid suicide and the lack of efficacy from the public, including the medical profession. We hand-delivered binders of these documents to the FDA, HHS, members of Congress, and the media. Because when you have seen in black and white what the companies and the FDA knew, while Woody and countless of others were dead, you never can unsee this, and something had to be done. So I'm going to just show you a couple of a sampling of some of the internal company documents and FDA documents that were obtained and declassified during my litigation. This first one is one that's near and dear to my heart because it was the South African regulators writing to Pfizer's chief medical officer, telling them that they had doctors reporting that they have patients on 50 milligrams, which is what Woody was on, saying that they stood outside their body. And Pfizer responds back, oh, what you're describing does indeed occur on all SSRIs. This next one was, it was prepared for, I think, Pfizer, Ireland, and where they had to look at all the clinical trials, not just the 2 that the FDA requires. And they looked into all the cases of their initial clinical trials. And here's what I thought was interesting. And this was a summary of the suicidality and suicide events. 31 to 40 years old, 1 to 30 days, and 50 milligrams. All 3 were Woody. This next one is a journal article that Pfizer chief medical officer wrote about akathisia, which is this head outside the body and extreme internal agitation. And he describes that it's, if a person experiences it, quote unquote, death can be a welcome result. While this document is not confidential, the next one is, and this is available and was out there, the next one is what was confidential. It was an article that was sent out to the product staff and salespeople that the attached article is not suitable for general practitioners, but maybe maybe of interest to neurologically inclined psychiatrists. So they basically, when 70 to 80% of your business is written by GPs, they kept it from the GPs. This next one was the FDA was asking Pfizer to prepare some things to do with adverse events. And Pfizer's internal email between employees were, do we want to give the FDA the simple, straightforward report, or do we want to give them the complicated, confusing one? I'm pretty sure that if I was running that FDA, I'd want the straightforward report, not the complicated, confusing one. This next one came from Pfizer, again, Europe, and it was talking about that the agency was looking at withdrawal. And it said, let's not volunteer a list of withdrawal symptoms, but be prepared in case they insist. Again, this should never be withheld from the public. And why is it a big deal? Well, here's one that came out of GSK's litigation on Paxil. That's because it's a $1 billion, this is their slide that they used internally at their company's sales meeting of why discontinuation, and maybe you don't want to tell people about it. It's worth a lot of money. This was an an initial clinical investigator, and why it's really important to get patient level detail is this was from 1983, and it was talking about a patient started verbalizing themselves, killing themselves and other people. And as soon as they got off the drug, it went away. And then here's another one where they thought it was interesting that the FDA was not at all questioning efficacy, while other significant questions regarding efficacy was being asked of them from several European countries. And then this was from, again, this was a Prozac, but I didn't realize that in Germany, Prozac wasn't approved initially for two reasons: efficacy question and suicide risk. And this was from 1985. Eventually, the drug did get approved in Germany, but it was recommended to be taken with a tranquilizer to offset some of the those activation side effects. And this was a memo from between the FDA, Bob Temple and Lieber, and it's talking about the regulatory, unless there's a lack of robustness. This was to do with sertraline, Zoloft. Then it talks about, I don't think we can be as demanding as we ought to be with establishing antidepressant products. And this is because it was during the AIDS crisis. They were getting a lot of pressure for not approving antidepressants. So they didn't think they could actually put a more demanding standard for efficacy. And again, I look at this was 1991. So at the end of the day, I look at this and say, this is DITA, which is at the time my litigation was happening. There were other major pharmaceutical litigations happening around Paxil, Vioxx, Avandia, Neurontin. And most of the lawsuits centered around fraud, failure to warn, and off-label promotion and marketing. Eventually, the companies settled massive settlements. And so this is a database. If you're not aware of it, you should be. If you want to get in, it's a great resource available that houses documents that have been obtained from lawsuits. It's the UCSF Industry Document Database as a depository for documents obtained in litigation. And it's eye-opening. It was originally created after the big tobacco litigation as a place to settle and house their documents. So whether it's big tobacco, Monsanto, big pharma, the companies often use the same playbook, which is overselling benefits and downplaying their product's harms, and the documents prove it. I also wanted to quickly mention a couple other types of lawsuits that we are now seeing in the current era of the public demanding more transparency since COVID. And that is FOIA, the Freedom of Information Act's lawsuits that are being filed against the government and other regulatory agencies. In addition, there are high-profile whistleblower lawsuits coming forward with reports of fraud, corruption within companies, institutions, and government agencies. So whistleblowers are always my heroes because they're the ones that come forward and do the brave, right thing. Another aspect I learned about was how pharmaceutical companies have to pay the FDA to review their drugs. This legislation was created after the AIDS crisis, where the public was outraged that the FDA was too slow to approve potentially life-saving drugs. So PDUFA was born. And PDUFA is Prescription Drug User Fee Act, and it was a law passed by Congress in 1992, which allowed the FDA to collect fees from drug companies to help fund their new drug approvals. PDUFA is a must-pass legislation every 5 years. Agreements are negotiated between industry and the FDA, and as part of their agreements, the FDA is required to meet certain performance benchmarks, primarily related to the speed at which the review process happens. And for a point of reference, over 50% of the total FDA budget comes from user fees. So some like to call this program the fox guarding the hen house. I have also been going to FDA Advisory Committee meetings since 2004 as a member of the public, testifying during the open public portion of these meetings. I have testified on a range of drug safety and other communication related issues over the years. However, in 2016, I was appointed consumer representative on the FDA Psychopharmacologic Drugs Advisory Committee, and am currently serving my third term. This is the committee of outside experts that review new drug applications and vote to recommend whether the FDA should approve or not. The FDA is not bound by the advisory committee vote. However, it usually follows their recommendation. And let me tell you, it's an eye-opening experience sitting on this side of the table versus being a member of the public who just gets 3 to 5 minutes to talk during the open public portion. I get an opportunity to review the clinical trials that are being, that the FDA is looking at, the FDA analysis, as well as ask questions of the sponsor and the FDA before voting. But not only do I like to challenge the science and the mechanics of the study, but really I like to talk about the potential marketing of the drug and the safety that comes from it. What I learned is FDA approvals can often be political and controversial. The gold standard of 2 double-blinded placebo-controlled studies seems to no longer be the norm. More and more of the drugs that we're reviewing are using some sort of fast tracking mechanism, using a variety of different pathways like breakthrough therapy or accelerated, with less stringent standards for trials. The narrative over the past several years that's coming from industry is that we need more innovative, more breakthrough therapeutic drugs on the market faster. The FDA is increasingly green-lighting expensive drugs despite dangerous or little known side effects or inconclusive evidence that they curb or even cure the disease. Often widely criticized for moving too slowly, today the FDA reviews drugs faster than any other regulatory agency. It seems to be the new standard way of doing business now. In prepping for my advisory committee meetings, I spend hours reviewing the studies, the analysis. I also have to oftentimes do some research on the disease and the current treatments that are available. And then I like to dive into the business side of the company. Having spent my entire career in advertising and marketing, working on a variety of different industries like cars, fast food, fashion, I'm used to doing deep dives into our clients' businesses, like a 360-degree investigation into all facets of their business model. Who's their competition, their target market, sales, marketing strategy. It's just how my brain is wired. So I naturally like to do that. Here are just a couple examples I want to just quickly give you on my from my perspective as sitting as the consumer rep, and I think it illustrates some of these issues. The first is Nuplazid, which was for Parkinson's psychosis. And this was a make or break for the company. So that made a light bulb went off. That means they had tried a couple times before with the double-blinded, the 2 gold standard way of getting the drug on the market and failed. So this was now using an unmet need as a way to get the expedited approval through using the breakthrough therapy designation by using just 1 clinical trial. I listened to the CEO calls and with Wall Street to just kind of understand their business strategy. And afterwards, I read a lot of market blogs, and a few of the analysts made comments about how this drug had the potential to be a $2 to $3 billion off-label drug for schizophrenia and others. So another light bulb went off, like, there's a huge sales potential for which is what investors love. And they were going to use it on small amount of data. So I had a lot of concerns. It was 1 6-week study, 199 participants. That means 95 on study drug. And that's a pretty small, short study, given the fact that somebody can live with Parkinson's for a long time. And, so ultimately, some of the questions I wanted to know is, how are they going to guarantee that they weren't going to promote it off label? because we all know that once a drug's on the market, the doctor can use it any way they want. But in the end, the advisory board voted 12-2 in favor of the drug. And I was one of the only 2 no votes. The other was from the patient rep who actually lives with the Parkinson's disease. And I have to say, I left deflated, I often do, wondering that people and families are going to be thinking that this is the holy grail and be given a false sense of hope for their loved ones. And I remember, because there were deaths that were seen in the clinical trials, I remember thinking this is ultimately going to end up in trial lawyers' hands. And certainly, sure enough, a couple of years later, I get contacted by CNN and a couple other investigative journalists after noticing that there were high numbers of serious adverse events, over 6,800 and 800 that had reported deaths to the FDA. Now CNN wants to know why I voted no, but they weren't interested at the time. The next is quickly is Chantix, and that was the removal of the black box warning. And this is a smoking cessation drug. And I was excited to be on this, the committee that was going to look at it, because if it takes a lot to get a drug or a black box warning put onto a drug, but to take it off, the standard should even be higher. And interesting, the black box warning went on because there were over 2,700 lawsuits that were secretly settled, and every one of the people that took a settlement could no longer do advocacy. So people like myself had to get out of it, and they were silenced. So that is when Pfizer went to the FDA with a new study and said, hey, we've been doing a new study. We're not seeing the neuropsychiatric side effects. So I thought, well, this is going to be a good opportunity for me to ask, where are the victims? Let's look into the lawsuit. What do we know? We know from, just seeing with some of the documents and experts that go in and see the files. I wanted to hear from them. However, a few days before the FDA advisory committee, I got a call from the FDA that had been brought to their attention that I had an intellectual bias. I didn't even know what that meant. And I could not sit on their committee. And so I wouldn't take no for an answer. And I'm like, all right, well, since I can't be there, can I at least come as a member of the public and speak so that I can give them my thoughts about, because I told them if safety is considered an intellectual bias, I will always have an intellectual bias. In the end, I wasn't able, but I did show up. And ultimately, my public record didn't get put into the official record. I don't even know if it was considered, because ultimately the FDA, in an unprecedented move, removed the black box serious neuropsychiatric side effect. These issues for the drugs didn't go away, just the warnings did. And then there's the most recent Resulti, that was an antipsychotic where they were trying to get an additional indication for Alzheimer's agitation. The drug, this just happened last year, the drug had marginal benefit over placebo, but yet it had twice the death rate over other antipsychotics on the market. I was the only no vote. And ultimately the FDA approved it, and it's being touted as the first and breakthrough, going back to some of those words that are basically just fast-tracking mechanisms. If you're interested, you can read more about my analysis on my Substack, as well as there's some really great reporting that was done in the British Medical Journal. So ultimately, my observations are many of the committee members vote yes during the voting period. However, it's really important to always listen to the rationale why, because many members you'll hear will say, I don't think safety is as strong as it ought to be, but they still assumed that having the drug on the market was more important, or that they assumed that any safety would be picked up with companies' REMS, the risk elimination mitigation strategies. And so the reality is just the tally of the vote gets in the news and not actually what people say. Also, the open public hearing is often stacked with pro-drug company speakers that have ties to the sponsor drugs. They tend to amplify, reinforce the message of the sponsor drug, and they nearly almost always come out in favor of a drug approval. There are usually a handful of patients that participated in the clinical trials that will come. Their travel was paid for by the companies, and they come, and obviously it was successful for them. But I always say, where were the ones that got hurt or got out of the clinical trial? We never hear from them. And this is just a quick shout out to Sid Wolf, the late Sid Wolf. His organization and another National Center for Health Research are usually the only that have no ties to industry that come out. And when they're there, you always want to sit up straight to listen to what they have to say. The AdComs meetings, in my opinion, should be an opportunity to debate if there's controversy, or especially if safety, especially if there's different points of view. And I learned this back in the antidepressants. The people like David Healy, who had information on the antidepressants, was given 3 minutes during the open public hearing. No, I think if we're going to be talking about safety issues, that we need the people with the other points, the safety, and we have like a debate so we can actually tease out the information of what's more important, because that to me is really where that tension is, where the truth lives. And advisory committees also need more non-conflicted, independent physicians and researchers and consumers that are focused on safety. We need healthy skepticism. A lot of them come from academia, and when your school or university that you work for gets funding from pharma, it's really hard. Even if you don't personally take money, it's hard that they may want to, it might self-censor themselves because they know their university takes a lot of funding from the industry. And then, of course, I always say journalists should be more, more interested in the explanation and less on the tally. At the end of the day, I always say this, I learned that FDA approval does not guarantee safety. I think it's important that our doctors also understand the difference between what an approval authorization, as well as the limitations of this, because if they don't know, then we, the unsuspecting public, we certainly can't know. And then along the journey, I've also learned that pharma marketing is often behind other activities that influence medicine, science, and cloud transparency, like the patient and disease groups. Not all patient and disease groups are created equal. Many of them take pharma funding, and in many ways have become extensions of the marketing department. I like to call them AstroTurf groups. They get funding from pharma. They are social media companies that pharma hires to find patients that also basically do nothing but promote their product. It's just something to be aware of when you hear all these organizations or individuals are touting new treatments. Like disease and patient organizations, not all medical information is the same either. Ghostwriting. This one is a document that came out of the litigation, where Pfizer already knew where the articles were going to run, but they didn't have any authors. So it's author TBD, author TBD. This to me is frightening, because when when they're in journals, those are what our doctors read. And so, we rely on these medical journals and to make informed treatment decisions. And if ghostwriting, and usually ghostwriting written articles usually emphasize the benefits of a product, which may mislead doctors and patients that think it's safer than it is. Then there's key opinion leaders, which, pharma knows the power of key opinion leaders or influencers, and they work hard. There's companies that do nothing than identify these doctors that they can use. And, often they play an integral strategic role in helping target their audience and bring credibility to the research that the companies have. And I believe that there are some that honestly have no idea that they're unaware of the marketing messages. So, and obviously in the case of opioids, we learned a lot about this. Then there's screenings. This one on the left, the PHQ-9, that screening form was created by Pfizer. If you look at the bottom, it says Pfizer Inc., and it has key opinion leaders on it. What I thought was interesting is, I shared this with my doctor and had no idea, because this is what they use at every appointment in our health system. And I said, did you ever see the bottom who it's from, what it's, and she said, no. And it's funny because as somebody who actually created lease ads for cars, I learned a long time ago, the disclaimer copy, the tiny type is actually where the truth lives. Like I remember you would never get a BMW when I helped create those programs for $350 a month. You had to actually find out, oh, I have to put $20,000 down. So anyways, and then obviously there's the pain scale that that Purdue helped create. But these are classic sales funnel tools where you get people up here, bring them into the funnel, and now you're converted from the public to customers, or I like to call patients, and into sales. And at the end of the day, as John Ioannidis said, writing guidelines is like prescribing something to millions of people. So they influence the prescribing or the guideline committees as well. And then of course there's medical journals, which we've heard a lot lately, the publication bias, selective publication, reprint revenues, that the companies, they buy these and then use them in their promotion. And I like to call them sometimes even advertorials. They're editorials, but they're really advertising and promoting a product. And I love, and I'm sure many of you have seen this before, but it's Marsha Angel just talking that much of the research that we cannot trust. And she came to this conclusion after her 2 decades of working at the New England Journal of editor. Pharma's influence is everywhere. In my over 2 decades of advocacy, I've come to understand that healthcare is big business. Pharmaceutical companies are sophisticated marketers. They know how to employ all the methods to reach consumers, providers, healthcare providers to ultimately drive sales and maximize shareholder profits. Behind every pill and medical treatment, there's a web of powerful self-interests. The public without their knowledge is increasingly being influenced by those with deep marketing pockets. And ironically, it was my late husband that always told me, just follow the money, Kim. And this is exactly what I did. When I started to connect the dots, it's kind of reminded me of a spider web. Strong yet delicate, transparent yet obvious, a trap where innocent prey get unbeknowingly often get stuck in their spider web. So I created the spider web with the doctor and the patient in the middle, and I have a lot of different elements from anything from the pharma lobbyist, ghostwriting, disease guidelines, the FDA are trapped in this web. The advertising to doctors, to consumers, what we're seeing, the letters to editors and opinion pieces that are going in our newspapers, all the celebrities, spokespeople, influencers, screenings, the media. I'm looking at some of the media. It seems that a lot of the mainstream media is, because of the advertising influence, is being kind of co-opted, and that's a problem. You've got the medical societies, patient advocacy groups, Congress, the programs of Medicare, Medicaid, the patent system, and even insurance. So I think you could actually do an entire seminar on just deep diving on this one slide alone. But again, all of this is going on behind the scenes while the average person, the everyday person like Woody, went to his doctor and trusted that the drug he was given was going to be safe and effective. Spider webs are sticky, transparent, and even intriguingly draw you in. So in closing, I think critical thinking and the ability to have conversations with differing opinions is a must. And I leave you with one of my favorite quotes by Albert Einstein, which is, "I have no special talents. I'm just passionately curious." And being curious and open-minded are essential to problem solving and learning. When we open the door to increasing our knowledge and understanding, we grow in innovation, creativity. I mean, these issues are not black and white, safety and benefits. It's both and it's shades of gray. So ultimately for me, I only wish that we asked harder questions or knew any of this information at the time of Woody's death almost over 20 years ago. It's too late for us, but it's why I do and have dedicated my life these past 20 years to do this work, because I don't want any other family to get the call that we did on August 6, 2003. So thank you so much for letting me come before you and present my opinion from my perspective. And here are my contact info if anybody wants to stay in touch.
Kim, thank you so much for this very powerful and very inspirational journey that you took us through, and very informative. We have a few minutes left, so I would invite the audience to turn on their cameras. And Kim, if you stop sharing the screen, then we'll be able to see people's faces and them raising their hand that they'd like to make comments or ask you questions. And I did notice there were a few very useful links and comments in the chat, and we will make sure to put these links on our website and under the video description on the YouTube channel. So yes, please raise your hands or to make any comments or ask questions. I can start with the first one while people are gathering their thoughts. So perhaps you've seen a very recent article in Stat by an academic from Harvard suggesting that antidepressants should be available prescription-free over the counter. I was very shocked to see that, especially after the avalanche of the research and amazing work done by many people actually in this room at the moment. How are we arriving to something like that, especially now when in the US overprescription of antipsychotics remains very, very high?
Yeah, I was going to say, for one, when I saw that, I about jumped through my computer screen and because we work so hard to get these black box warnings on and to sell them over the counter. These are not benign, daily vitamin drugs. And then I was really curious, like, who was this guy? So then I was like, oh, does he have any industry like, where's his ties to industry? What, I always think that's a very important thing to go look at. But then I also look at what's happening in society right now. You have, since the pandemic, we've got, the mental health is skyrocketing, antidepressants are skyrocketing, the Gen Zs are coming out and they're actually calling antidepressants hot girl pills. Or they're calling it, like, they're all like super proud of their diagnosis. Like, I've got anxiety disorder, I'm Alexa Ho and Alexa Bro. And all of this is adding to this culture that these are just safe and, just pop them when you want. But these are serious mind altering drugs. And to my opinion, like when I look at that one document that still talks about Woody's age, we have not yet even had warnings that all ages. And I know that, Peter Getchy and wrote an article, like, we're using, like, these drugs are like, because doctors have bought into this and it was based on medical journals and that have been around, they just think they're safe and effective. And I think, we've got a big problem, and I hope, and we will fight, because I don't think they should ever go on. I'd also be very surprised that they would go on, but you never know.
Indeed.
Where can we raise our hand?
Just go ahead, Peter. I can see.
Oh, because I can't see any hand anywhere.
I can see you, so please go.
Okay. I just wanted to thank him and tell you that when I published my article a few weeks ago, that our prescription drugs are the leading cause of death ahead of heart disease and cancer. I was told by Bob Witczak that I had been conservative. So, and I agree with him. I've tried to be conservative, so don't doubt that our drugs are the main cause of death, and psychiatric drugs are really a big part of this. So thank you, Kim.
Thanks, Peter.
Any other comments, questions? There was a comment, Kim, in the chat. It's slightly on a different topic, but this may lead to actually epidemic in the cooking and in terms of Ozempic. And I guess the question to you as a advertisement pro guru, what do you think about the current campaign around not necessarily just Ozempic? There are many other similar drugs coming to the market to also treat the population which thinks it's a miracle because they don't need to do much, to just inject themselves or even take the pill instead of doing the hard work, not realizing the long-term benefits and losses, basically. What is your interpretation and where do you think it's leading us?
Well, I find it fascinating. Again, it goes right along with culture, quick fix pill. I mean, yes, obesity is linked to a lot of things, but I wonder how many people actually understand the harms. I was recently with some people that deal with reinsurance, and they're the companies that actually insure the companies that are going to have lawsuits. There are going to be litigation. They're already telling the companies the number I was told was $500 million every quarter. So that means that they know there's a flood of litigation that will eventually come. And when that happens, that means people were hurt. And even now, like, especially if people are ashamed, I heard from an anesthesiologist that even if you go get your teeth, do something at the dentist, you better be really honest with your dentist and not be shameful that you're taking this medication, because you can have issues when you go under anesthesia. So I think it's it falls in line. You got Weight Watchers, you got the Weight Watchers who they were all about like fuel in, fuel out. They're now putting Ozempic at their clinics. You've got the gym and the health clubs here in the US that have the ability to get the Ozempic shots at the gym. So to me, it's a culture. They think they're doing it as for helping people, and it does. I mean, obesity is a huge part of leading to other diseases, but it's one that's definitely ripe, and I am terrified to see what's going to happen eventually down the road.
Indeed, it's a very big business. You also
and I was going to say, one of the things I love to do is see what JP Morgan, every January, they have the JP Morgan Healthcare Conference. And I went and saw that the two big industries that they said, this conference is not for, people like me, it's really for the industry, and said the two biggest areas of growth are Alzheimer's and obesity. And they said obesity is about a $30 billion a year annual profit for companies, or sales and companies.
Thanks. I didn't ask you for this, but you actually advertised one of our events that we will be hosting in autumn, actually looking at Alzheimer's and obesity and how it might be modeling cancer research, what happened with oncology, and then now taking it to a very consumer level, diseases basically where massive populations will be affected, perhaps much greater than cancer, because if we look at cancers and totality of different cancers instead of individual cancers. So Yes, it's huge. So do join us in autumn and watch out for the announcement. So we stay tuned. Extremely interesting points you brought up in terms of connecting. I think the bits that we've discussed on other events in terms of conflict of interest, also bringing in the guidelines and the financial conflicts of interests and especially the FDA. But even though you put American perspective forward and outside the US, it might be less visible, but I think it should not be underappreciated that prescription of antipsychotics and especially antidepressants is massively increasing in Europe and has been increasing as well. So to me, it's I really struggle to understand how exactly it's happening, because after working at NICE, you think the system is almost bulletproof. It should be, it should know better, but the industry knows what they're doing and how to get to where they need to get. So and unfortunately, the picture you painted in the US, it might not be to that exact extent, but it is not just the US problem.
Yeah, and I was going to say, I just was scrolling through the comments, and there was one that I just want to ask where it says, do I feel like there's a link between the mass shootings and antidepressants? And I think there's one that we definitely need to investigate. Yes, I do think there is. I mean, if you go back to the 1991 hearings, that was on the emergence of violence and suicide. And one of the another documents that came out that were, I didn't show you, was talking about fluoxetine, which was Prozac, and Pfizer saying that I don't think they're out of the woods with their association with violence. And Pfizer also had a litigation manual, the Prozac or the Zoloft litigation manual, and it was for those that used the Zoloft defense, saying the drug killed me. There have been massive courtroom hearings, you know, we're going to continue seeing it unless we start investigating. And we have been asking the US government to investigate, and there has been no doing. Again, it doesn't say causation. It's about, we need to have an investigation, because there clearly has been links that at least the documents have shown that they've been aware of the correlation that there might be between the drug and violent act. Violence against yourself, violence against others.
A quick question, if we could. These are Charlie Bennett. Ken, great presentation. And we learn something every time we listen to more of you. So thank you.
Yeah.
And opening the black box of what happened in the FDA panel is great. We want to say the work we've done, as you know, on the Cipro and Levaquin, we did a comparison of the FDA advisory board to the EMA advisory board from patients. It was quite interesting. So the EMA, when they had an advisory board for patient interest, patients were given 3 questions that they must address when they had open microphone. And they had to write them down before the meeting. And they had to prepare them, and they reviewed. The ones that were selected were picked from the ones that they reviewed positively. And they were given 5 minutes and a plane fare and a hotel to present in Europe, in London. And they were also given 3 minutes of Q&A back. Whereas at the same time, for the same question, the FDA had 3 minutes, as you mentioned, with the red light that comes on with no questions allowed. My question is, as you talked about, why can't we be more like Europe?
Amen. I mean, and I know the Europeans might say something different, but I would say that there were some drugs that we had on our committee that that Europe took off. And I'm like, why aren't we at the FDA, when we're looking at approving this drug, why aren't we hearing from the European regulators? Why aren't they here presenting? Because if we're going to approve the drug, I want to know why Europe, why the UK took it off the market. So I agree. I think this whole idea of picking who gets to actually present at these hearings at 3 minutes. Again, I go back to there needs to be public debate. I just don't think people really pay attention to this, honestly. I mean, you know, if the average person doesn't even think about this, they don't, you know, I think people are just living their lives. And I think doctors kind of fall into that same thing and that same trap as well.
Thank you, Kim, and thanks for your question, Charlie. I think at this point it's a wonderful transition because you are giving the next talk. So on the 16th of May. So it's an introduction to it's a spoiler for our audience. So we look forward to seeing you in May. Kim, huge thank you for all the work you've been doing over the 20 years and how you converted a very personal tragedy in such a powerful tour de force to really try to change the world. And I guess little did you know how hard is this world that you're facing, but a lot of people are working on this, and one way or another, even if we cannot completely win, there is a way to at least raise awareness and increase education to save more lives.
Yeah,
So
thank you for I was gonna say, thank you for having me. I, by no means, anybody who knows me, it's like, I always say it takes all of us all doing our part. And there are a lot of people here that I see on the list or on this Zoom that I know are big heroes of mine. And so I think it takes all of us, and it's about kind of bringing the information from bottom up so that we can actually start getting people to pay attention to this in the general public. So thank you, everybody, for allowing me to tell my story and share it with you guys.
So thank you very much. And we'll look forward to seeing you in a couple weeks. All the recordings are available online. This video will be available tomorrow. And do check out the previous meetings that we've had touching on the conflict of interest. A lot of very interesting information. And once again, thank you for all the comments in the chat. These links will be made available. All right. Have a good evening, everyone. Bye-bye.
Bye, thank you.